Hello and welcome to the first webinar recording of the Age and Disabilities Odyssey Conference. The Major Change Initiatives Conference was recorded on August 22nd, 2023 and has been lightly edited for video. Unfortunately, we are not able to provide CEUs for watching the recording at this time. However, viewers are still able to self-report this conference in TrainLink. Instructions are in the description box below. We go now to join our MC, Todd Stump from the Aging and Adult Services Division, as he introduces our first presenters.
And now, I'm happy to welcome Heidi Hamilton, Disability Services Director, and Rachel Shands, Aging and Adult Services Home and Community-Based Services Manager. They will be providing a brief overview of the major changes that will be discussed today. Take it away, Rachel and Heidi.
Good morning, everyone. I'm Heidi Hamilton, Director of Disability Services, as Todd said. I'm happy to welcome you today and thank you for attending today's webinar. This webinar will discuss the 4 major changes happening in the Aging and Disability Services Administration. Our staff have been working very hard and we're excited to share this information with you today. All changes that we're talking about will increase choice and control for people using our services. These major changes affect older adults and people with disabilities who use home and community-based services. We'd like to thank the counties, tribal nations, managed care organizations, and providers, as well as those receiving services from us and their families that provided input and engaged with us in a variety of ways during the planning and implementation of these initiatives. Your feedback was and continues to be invaluable as we improve our systems that allow Minnesotans to live their best lives.
And good morning, everybody. I'm Rachel Shands. I'm a Community-Based Services Manager in the Aging Division. The 4 changes that we're going to discuss today are electronic visit verification, or EVV. This is a system to document the services people receive in their homes and communities. MnCHOICES revision project, an update to the tool used to conduct assessments and create support plans. Community First Services and Supports, or CFSS. This is a program that offers flexible options to meet the unique needs of people and allow them greater independence in their homes and communities. And finally, Waiver Reimagine. This is ongoing work to make system-level improvements to Minnesota's 4 disability waiver programs. These changes will affect or have already affected a large number of people with disabilities and older adults receiving services. For example, it's estimated that 150,000 people are impacted by MnCHOICES revision, and Waiver Reimagine should impact more than 60,000 people. Many people will experience or have already experienced these changes at different times. EVV is already underway with many personal care services enrolled in the process. The MnCHOICES revision project launched phase 1 on July 10th of this year and will continue to move through 4 phases by May 31st, 2024. DHS will announce the CFSS launch date 3 months beforehand to give people time to prepare for the transition. Once CFSS launches, people can access the program at their annual reassessments. And DHS will continue to simplify our disability waiver programs and collect a full year of new MnCHOICES data before we launch Waiver Reimagine for the public. We will share more details about Waiver Reimagine in the upcoming years. Let's go to the next slide. Please make sure you subscribe to our e-list communications to receive updates on each of these initiatives. Our e-list is a method to communicate updates, initiatives, and policy changes from the Aging and Adult Services Division and Disability Services Division in a simplified way. We send this announcement every week on Tuesdays. The PDF of the slides, which was emailed to all registrants last Thursday, has a link to subscribe to the e-list, and we're also currently sharing a QR code that can be scanned to subscribe as well. Now we are excited to turn it over to our staff to give you more details on each initiative. So here to share more information about electronic visit verification, or EVV, are Amanda Tamte, EVV Communications and Training Coordinator, and Libby Rossett-Brown, Human Services Program Consultant for Elderly Waiver Policy.
Good morning. Thank you. We're going to give you some background on EVV, electronic visit verification today, and provide you with some information about where we're at and how these changes are impacting Minnesota. So I will hand it off to Libby to start. Next slide, please.
Hi, I'm Libby Rossett-Brown, and I'm with Aging and Adult Services. And I just want to start with, what does electronic verification mean? So electronic verification is an electronic system to verify when home and community-based services are being provided. DHS, or the Department of Human Services, allows flexibility with this electronic system so people can receive supports in the community, at their place of employment, or in their own home. One example is that caregivers will clock in and out at the beginning and end of the shift using their cell phones or another approved device when providing supports. Next slide, please. So why do we have to implement EVV, or electronic verification visit? The 21st Century Cures Act of 2016 mandated that states implement EVV for all Medicaid personal care services, which includes some waivered services and home health services, through an electronic verification system. It's a federal law requiring providers of affected services to implement EVV in collaboration with the Minnesota Department of Human Services, DHS. Part of the federal law is to ensure that people are receiving services that they are authorized to receive and to reduce fraud, waste, and abuse. DHS will provide guidance and policies to provider agencies implementing EVV to ensure that the requirements of the 21st Century Cures Act are met. To see a list of the mandated services, visit the MnDHS EVV webpage under the Required Services tab. I will now pass it on to Amanda.
Thank you, Libby. My name is Amanda Tamte, and I am the EVV Communications and Training Coordinator. And some of the required, or while the required data, there are 6 elements that need to be collected to be a confirmed EVV visit. And so this is the type of service that was performed, who received the service, the date of service, location of service delivery, who provided the service, and when the services start and ended. EVV is required for all mandated services, regardless of where the services start and end. So this means that service could either start in the home or in the community of the people, for the people receiving services. Through EVV, next slide, please. Sorry. So Minnesota key legislative principles. Minnesota state law reflects and expands on the 21st Century Cures Act requirements to implement EVV in a way that is minimally burdensome, doesn't impede the matter of which care is delivered, or the person's selection of caregiver. State law requires that we implement EVV in a way that it does not impact the services that people receive and is in accordance with the DHS policies. Next slide, please. So through the implementation of EVV, we have received partner feedback throughout the whole process. Some of the key things that people said was that the application be as mobile as the people using it and support the individual wherever the person lives. This also includes supporting them wherever their services are received, whether that's in home or at the community. They also ask that we avoid rules around scheduling, that it's not a requirement. So ease of use for schedules and flexibility in who provides the service. Adaptability if there's no internet access or access to a mobile device. prioritize the ease of use regardless of language or ability, and minimize privacy intrusion, including those created by collecting the location of service delivery. Next slide, please. So now I'm going to take you through the approach Minnesota has been taking throughout the implementation of EVV. Minnesota chose the hybrid model for EVV, which means that a provider can either choose to use the state-selected EVV system, which is HHA Exchange. This is at no cost to the provider, or they can choose to use a third-party EVV system that meets the state requirements and is able to connect with the data aggregator with HHAX. This could mean that a provider already has an EVV system in place and wants to continue to use it, or wants to obtain a third-party EVV system to implement EVV for their organization. Providers will choose what works best for their organization. For the third-party EVV systems, providers are responsible for the costs associated with those third-party systems. DHS chose to implement EVV in a phased approach. This allowed us time to, and flexibility to onboard people into the system. So we first implemented EVV for financial management services for personal care on June 20th of 2022. We then implemented the remaining personal care services on December 12th of 2022. We just recently launched for managed care organizations for personal care on June 5th of 2023, and we are set to implement for home health services, fee-for-service, and MCOs in October of 2023. This will be our final phase for implementation. We are implementing in a soft launch approach. Next slide, please. As I said, we're implementing in a soft launch approach. This allows time for providers to onboard into their chosen system, and this also allows time to onboard caregivers and members. We understand that it'll take time for it to become routine for providers, caregivers, and members, and providers will receive notice before full system usage is required. Next slide. To maintain the minimally burdensome, DHS has chosen to continue with the current billing process through the implementation of EVV, which means that EVV does not impact how providers bill for their services. We're using a post-payment review, which may result in takebacks from providers if claims are not supported by EVV data. At DHS, we continue to explore billing enhancements in the HHAX system to be able to use in the future. Next slide. We recently posted EVV policies to our EVV CBSM. These policies include for live-in caregivers, device usage, and verification methods. We developed these policies using information from the first two phases of implementation. Providers may create additional policies to meet their business needs by using the DHS requirements and policies for EVV. Next slide. When we developed the live-in caregiver policy, we understand that this is a 24-hour job for people. So we wanted to make sure that we provided guidance for live-in caregivers in the EVV system to keep it as minimally burdensome. So live-in caregivers are exempt from some requirements according to the federal guidance that was put out by CMS. DHS does not require live-in caregivers to interact in real time with the EVV system. Live-in caregivers must enter the required EVV data at least once per day, but providers may choose to require live-in caregivers to interact in real time. A live-in caregiver is somebody who has a shared address with the person receiving services, and providers are required to ensure that these addresses are kept up to date to maintain the live-in caregiver status. Next slide, please. Devices for implementing EVV. So within the HHAX system, DHS is taking a mobile-first approach to verify EVV visits. We have found that the majority of people have mobile devices, and so the caregivers would then download the application on their smart device and then verify visits through the mobile app. We have recently added a second option, which is the interactive voice response, IVR, which is the use of the telephone system to verify EVV visits. Providers using a third-party EVV system will need to work with their vendor on device options for EVV. DHS does not oversee devices for third-party systems. Providers can use what works best for their organization if it captures the required EVV data. Next slide. With implementing EVV, it is important to maintain confidentiality for those within the Safe at Home program. So DHS has been working with the Office of the Minnesota Secretary of State to ensure that we have the best approach for participants in the Safe at Home program. A participant can be either the person receiving services or the caregiver, or they could be both. So at this time, participants in the Safe at Home program who receive or provide services in scope are not required to use the EVV system, regardless of what the system chosen by the provider. We are working really hard to determine the appropriate options to ensure that people's information remains confidential. Next slide. There's a lot of training available to providers. For those that use the HHAX system, there's webinar trainings. They have a learning management system, LMS, where there's videos and guides available. And there's also job aids and guides in their provider portals. And these job aids and guides can be used to train the caregivers and the members on how to use the system. Third-party system users also have access to the HHAX learning management system to be able to navigate the data that is being sent from their system to the HHAX system. They will then need to work with their vendor and ensure that they have the proper training to use their system. Providers are responsible to train caregivers and members to ensure they feel comfortable with the provider's chosen system. DHS continues to explore options on how to assist with trainings for all, including providers, members, and caregivers. Next slide, please. We understand that there are language barriers throughout Minnesota, and so we wanted to ensure that the mobile application and training materials were available in multiple languages to meet the needs of Minnesotans. The HHA mobile application also uses visuals, which makes it easy to use even when language is an issue. We have also had training materials translated currently in Spanish, Hmong, Somali, Vietnamese, and Russian, and continue to explore what expansions we need to make for language needs. Providers that use a third-party EVV system will need to work with their vendor to meet the language needs of the people they serve and their caregivers. Next slide, please. We're committed to engagement throughout this entire process. We have met with partners in the beginning and continue to meet with them as we move through each phase. We have, this year we have added EVV quarterly update sessions that are hosted by DHS. We provide updates on where we are at. And so if you would like to get notification for those, please sign up for our e-list announcements. We continue to update our webpage to try to have the most current information. And then we also have a mailbox where people can reach out to us with any questions that they have. Next slide, please. Here's some additional information and resources for people to review. We do have a Minnesota DHS FAQ. We have our CBSM where all our policies are posted. There's a web page through HHAX and for providers to get the most current information with HHAX, but we also have a DHS EVV specific web page. There's also background on the process of the 21st Century Cures Act and the Minnesota statute. Next slide. I want to thank you guys for your time today and letting us talk to you about EVV. The contact form to contact us with further questions and our webpage are on this slide as well. So thank you again and enjoy your day, and we hope you get a lot out of today.
And now we'd like to turn it over to Lori Miller, Assessment and Support Planning Supervisor, and Darci Buttke, Home and Community-Based Services Supervisor, who will be sharing information about the MnCHOICES revision. Welcome, Lori and Darci.
Good morning, everyone. I'm going to start us off today. So my name is Darci Buttke, and I'm the supervisor for the Home and Community-Based Services Unit in the Aging Division. And I'm here with Lori Miller, the Assessment and Support Plan Supervisor for Disability Services. Next slide. So today we're going to talk about the revised MnCHOICES application. So you're going to hear terminology about MnCHOICES 1.0, which is the original and current MnCHOICES assessment and support plan application. This project is specifically about MnCHOICES revision, which is essentially an off-the-shelf product, and we are on contract with a vendor to customize and configure their platform. So first we want to talk about just what is it and why did we go to a new system, and kind of talk about how we got here. So there were a lot of benefits, but a lot of also efficiencies that we wanted to provide by using a new system and working with an outside vendor. So this gave us an opportunity to really look at our content and understand how we can remove duplicate questions within the assessment. But one of our biggest enhancements was that we were able to get all users into this system, meaning managed care organizations, as well as our counties, and then some of the tribal nations. Next slide, please. So some of the benefits of this project and also moving to this system is that we were able to look at the workflow. We were able to obtain some features where DHS can actually manage some of the content right within the system. There are certain features that we have availability. We were able to hand over a portion of accessing the users to the lead agencies. So lead agencies are able to create those user accounts, and then there is a second half of that setup where the DHS and Minute Help Desk provides that other portion. But this was a big enhancement for the lead agencies to be able to control their own users. We're able to connect our assessment and support plan. So as I said, in MnCHOICES 1.0, we have two separate computer applications that are being used to develop that, to conduct that work. Now it's all in one place. We were also able to utilize having help scripts and they're called tooltips, or we're able to give real guidance and help with how to fill out each of the questions within the assessment and support plan. But there's also a place within the system called the Help Center. And we're able to put guidance documents. They're called smart guides. We have micro learnings, which are little videos on how to do the work, and the users are able to access it right within the system. Next slide, please. So why did we do this? I mean, for all of the reasons that we talked about before, but also we were required to. So in statute in 2016, we were directed to enhance the assessment and support planning process. And as that analysis was being conducted, it really landed on us with looking at a third-party vendor. So FEI Systems is the vendor. They're on the East Coast. They work with multiple states. As the work that we're doing with assessment support plan is not unique, right? It's not unique to Minnesota, and all states have this process. So we were able to utilize their system and then customize it to our needs, or configure, which means choosing kind of what switches we want to turn on and off in their system. But we also want to make sure that it stays compliant. And we're able to also go through a second process, which is called a CMS certification. And we are working currently actually on getting this system certified because it is a system that determines eligibility. So we are very compliant in that area and ensuring that nothing changes. So the next slide, we're going to start going through kind of the timeline and the history. So when we initially kicked off this project was right during COVID. So September of 2020 is when the contract and the project officially started. During that time frame up until July of 21, we were in very deep sessions with the vendor, trying to develop the business requirements to actually develop the content. So the three main items that are in this tool are the MnCHOICES assessment, which determines your waiver eligibility, or PCA. Then you have your corresponding support plan. And then we also have the health risk assessment. And this is an assessment that is done by the managed care organizations. So this was a very exciting addition that we were able to put in for this additional user group, because the health risk assessment was done on paper. So in July of 21, the training zone was created, which allowed our users and DHS to have access to a practice area, essentially. We then conducted functional testing, which means you're really making sure that the system has all of the questions and the answers populated as we requested, and that it had, they're called business rules, but that things were functioning as they were supposed to. And we had 16 individuals from the managed care organizations that helped us do that testing. Then in March of 22, we started doing testing that we called assessment and support plan accuracy. And this was to ensure that the assessment did what it was supposed to do. The assessment determines level of care as well as waiver eligibility. Did it do those things? Because that's one of our core goals and thing we had to make sure worked correctly before we released this product. Then we also needed to make sure that within the support plan, rates were being calculated correctly. Again, core function had to be working in order for us to ensure that we could launch the system for lead agencies. So during that time, we had 15 county and tribal nation participants. Go to the next slide. And then we did some additional testing in December of 22. And this was called user acceptance. So basically what this means is that you're taking real scenarios of actual people or situations that have come up and running those assessments and support plans through the whole process. Did the assessment give the result that we would expect? And then were we able to do that support plan for that specific person? So they were fake people, but a user acceptance is really based on a use case, a type of actual situation. So during that time, we had all of our lead agencies helping us, and that was 13 counties, testers, 4 tribal nations, and 8 testers from the managed care organizations. So we do provide a link here to just have way more details than we're ever able to share with you today. That there's a link to get to that website, which is on County Link. Go to the next slide, please. And now we'll talk about the phases that we were in. So when we did that testing in December, we originally had a launch date of April, and then realized that we need to do, with feedback from our lead agency partners, which we appreciate, is that there's just a lot coming at the lead agencies right now with all the wonderful initiatives that are happening, but also coming out of COVID, workforce shortages, and realizing we needed to do a phased approach so that we don't have all users at once going into the system, needing support, learning a new system, because there are 5,000 users of this system. And so we're going to now break down the phases. So starting in April, we technically launched the system. It was live and it was in production. And then starting in May, we started with a group of 28 lead agency users who had access to a new training zone. The training zone that was initially provided, there were a lot of updates that were made over time, and we received a new cloud-based version, which is probably more detailed than you want to know, but it was something we needed to test, and we wanted our lead agency staff to help us do that, and also ensure that they could share and communicate on our behalf and for their constituents that this training zone was a zone that could be used for all users to make sure that they could use the system and learn it as we were going through this big change. Then starting in June, those same 28 lead agency staff got access to production, and that allowed us to actually do real work. And a big part of having these phases is also making sure that DHS was ready to support these users and work our processes and make sure that we can respond timely as questions and issues might come up. Because we have been very transparent that the system has defects. We are working through them, but it will always have defects. In honesty, every system does. We want to limit those as much as we can, but it's a nature of having computer applications that are very, very complex. But we want to minimize those as much as we can and ensure that we're getting them fixed as quickly as possible. We then went into phase one, starting on July 10th, which was considered our statewide launch, meaning a big email went out to all users to say, you now have access to the MnCHOICES system. However, we only want up to 10% of the users across the state to actually be utilizing the environment, because that allows us to somewhat control, making sure that we are able to respond, that lead agencies have a comfort level to not think that they have to support all of their own users as well. So that we're in phase one from July 10th until September 29th. And then our goal is to move into phase two, which will be having up to 30% of users. So we did not try to control what agencies were accessing the system, which users at which agencies. That was really done at the local level. We are just putting out this plan. We've developed it together, and this is what we want the lead agencies to help us manage. If you go to the next slide, it will talk about the last section of the phases. So then phase three is scheduled for December 1st through February 29th. We aim to have 100% of users in the environment. Phase four goes till May 31st. Basically what we want is for users to finish their work in MnCHOICES 1.0. So all throughout this phased launch of our new system, we are supporting the existing systems that I talked about. The MnCHOICES assessment and support plan, MnCHOICES 1.0, as it can be referred to, is also still being utilized. We have two systems that we're maintaining to make sure that users can finish their work in the old system and then move to the new system as reassessments or new assessments need to be done for individuals. So we are not doing any changes in MnCHOICES 1.0 except for when rates get updated. And that happens typically every January and sometimes in July. Next slide, please. So I'm just going to go over a couple more key points about the new system, and then I'll be handing it over to Lori. So how this project and this system connects with choice control really has a long history of when the MnCHOICES assessment was created. And there were several assessments based on the program that you wanted to access. So there has been a lot of focus on trying to make sure that we make this as simple, even though it's a very complicated process, as simple for the person as we can. And that was working really hard to create one assessment, which is known as the MnCHOICES assessment. We want to make sure that the assessment and support plan, which has obtained a lot of feedback and testing on, is that it's a person-centered conversation. It's about the person. It's not just asking a bunch of questions about them. It's making sure we understand what they need, and that support plan is based on information that is important to them. Next slide, please. MnCHOICES does have intersections of some of the initiatives we've talked about today or that you'll hear about. We're really excited about the potential of what this system, this computer application, if you want to think about it, and the opportunities that we can build upon. Right now, we have our waiver assessment, and support plan. We have the health risk assessment used by the managed care, but what else? What else could we add in there that is about the person? If we put the person in the center and the types of assessments or initiatives that are being done with them, how can we add it to this computer application? And some of that is with CFSS. So as we've talked about, or you'll hear about, is CFSS is replacing PCA. So MnCHOICES has already been programmed to determine eligibility for CFSS. And because of that, and knowing that we have connections with it, we've had to do some workarounds, and that's okay. It's ready. It's ready for when CFSS is implemented. And then, as we've talked about or mentioned earlier, the data being collected will support Waiver Reimagine. So even though we're all separate, we're all connected as we're serving the same people. So now I will hand it over to Lori to finish up our presentation.
Thank you, Darci. I am going to start with talking about equity. Equity is one of the many lenses we looked through during the build of the MnCHOICES and will continue to look through ongoing. Ensuring the MnCHOICES assessment and support planning is available to all Minnesotans in need of long-term services and supports regardless of age, type of disability, or service need is an essential part of MnCHOICES. Moving to having all lead agencies, that's counties, tribal nations, and managed care organizations, using the same application for the assessment and support planning is the foundation for building on equity. All lead agencies must use the MnCHOICES assessment to complete a comprehensive, conversation-based, person-centered assessment. Before assessors can conduct assessments, they must meet statutory qualifications. It needs to be a bachelor's degree in social work, nursing with a public health nursing certificate, or closely related field. And they must become certified assessors. They do this by completing the mandatory certified assessor training, known as MnCHAT, and then ongoing recertification. With all lead agencies using the same application and assessors receiving the same training, consistency in assessment results and support planning is improved. Also, the MnCHOICES revision is accessible and compliant with the State of Minnesota Accessibility Standard. The revision is compatible with screen readers. You can move to the next slide, please. How is Aging and Disability Services Administration, ADSA, supporting the transition to the MnCHOICES revision? At the user level, we talk about users as assessors, case managers, care coordinators. DHS has implemented many steps to support lead agencies in training their users and transitioning to the MnCHOICES revision system. Some examples of MnCHOICES user training and ongoing user support include monthly webinars for distributing information, demonstrating parts of the application, and troubleshooting with the users. On alternating months, DHS hosts a call-in session called Office Hours. This is a venue for users to ask questions and receive technical assistance related to both the current MnCHOICES 1.0 and the MnCHOICES revision. Online training modules, such as micro-learnings in the MnCHOICES revision application, they're available at any time. The application has a designated area for training and guidance documents. That's what Darci referred to as the help center in the application. We have created user guides, such as the MnCHOICES Assessment Practice Guide, to guide the assessor on navigating and completing fields with the assessment. We've also got smart guides that are step-by-steps on specific uses of the application. A DHS help desk where users submit help desk tickets is another resource. The subject matter experts provide technical assistance to those questions that come in to the person who submitted the ticket. DHS provides project updates and announcements through e-lists and on MnCHOICES County Link. MnCHOICES County Link is a website designed for lead agencies administrating MnCHOICES. It contains news and updates and quick links to documents assessors and support planners use. DHS also worked with the vendor, FBI Systems, to build a training zone, and Darci also mentioned this. This is known as the MnCHOICES Training Zone, or MTZ. That training zone mirrors the production environment as closely as possible. It's a practice area for assessors, case managers, and care coordinators where they can access to become familiar with the system prior to visiting with the person. Next slide, please. Thank you. With the implementation of MnCHOICES, referrals are made for an assessment with no predetermined program or service outcome. Having one comprehensive assessment ensures that people are appraised of all of their options. As stated previously, prior to MnCHOICES, people may have received an assessment for one service type and were often unaware of the multitude of service options available to them in Minnesota's long-term service continuum. MnCHOICES provides one entry point. That is one of the main ways that the application, MnCHOICES and MnCHOICES revision, assists the people and families. The application will determine eligibility and include support planning activities for the following programs and services: alternative care, developmental disabilities waiver, community alternative care, community access for disability inclusion, or CADI, the brain injury waiver, essential community supports, elderly waiver, and PCA, which at a later date will be Community First Services and Supports, CFSS. With both the MnCHOICES and assessment plan application in use, lead agencies have this single, streamlined, and comprehensive process to assess individuals, identify their needs, develop a support plan, and calculate rates, providing a greater support for a person-centered assessment and support planning. which is what we're looking for to assist families and people that are in need of services. You can move to the next slide. There we go. Some more things that assist people and families. The build of the revision provided the opportunity to reconcile policy and eliminate duplicate and repetitive assessment questions, resulting in a shorter assessment time. It also provided the opportunity to approve on the documents a person receives following the assessment. For example, the assessment summary is a summary of the assessment and now contains an introductory letter, summary of the assessment, assessment results, action taken by the lead agency, and the right to appeal. All this information is now provided in one document, so it streamlines our process. Next slide, please. So how does MnCHOICES impact or help the lead agencies? With all lead agencies, as I said, including managed care organizations, now using MnCHOICES for assessment and support plan, there will be improved communication across the agencies as people transition between lead agencies. The users can communicate with each other and transfer documents directly within the MnCHOICES application. The MnCHOICES revision has increased efficiencies and a more reliable platform. It has improved application response times, the reassessment workflow support. It has business content management, user access management by lead agencies. There's an automated enforcement of data and security policy. It's streamlined workflow and process between assessment and support plan. And we offer the real-time guidance for assessment practice provided in the application. Next slide. There is more on how we assist the lead agencies, and it's how they can prepare themselves. The lead agencies can prepare themselves for the transition to MnCHOICES revision by utilizing the MnCHOICES training zone to practice completing an assessment, health risk assessment, and support plan. This practice not only assists in becoming familiar with the forms, but also allows the user to become familiar and comfortable with the use of the application prior to going out on a visit. While practicing, the user may need assistance or clarity on specific areas, and they can bring those questions to the launch webinar or office hours for assistance. We provide direct assistance to the lead agencies to ensure that they understand, are now comfortable with using the application, because we know that that will impact the user's experience and the person receiving services. Next slide. So how does MnCHOICES impact providers? Case managers and care coordinators will experience a more streamlined process in offering choices and planning services with the person, as in choice of provider, determining what services are needed, amount of service, etc. But because policy is not changing, the use of MnCHOICES revision will have no impact on providers. Providers will not experience any disruption in services. That will continue as it has. Next slide. This wraps up the presentation from Darci and I on the MnCHOICES revision. It's a very exciting project, and we were happy to share that with you. But now we're going to pass it to the staff who will present on Community First Services and Supports, or CFSS. And I'd like to invite my co-worker, CJ Calton, Home Care and Self-Directed Services Communications, and Training Lead, to present, along with, we're going to welcome back Libby Rossett-Brown.
Hello. Happy and excited to be here today to present about one of my favorite things in the world, Community First Services and Supports. This is something that me and other members of the home care and self-directed services team have been working on for some time, along with our colleagues from Aging, including Libby here. So really excited to be talking to you about it. Next slide, please. So just start with a fairly simple statement for those unfamiliar with CFSS. It's going to replace PCA, or Personal Care Assistance, and CSG, or the Consumer Support Grant. Next slide, please. So I just wanted to talk quickly about similarities with PCA. There's, people, when they hear about something replacing PCA, which has been around for decades, they are understandably worried about, is that going to result in them not being able to access things they're currently accessing? And that's a very understandable concern. So just wanting to clear that up. Can we go to the next slide, please? So eligibility for PCA is the same as eligibility for CFSS, although you see that I've got in parentheses there mostly. And that simply refers to there's a home care rating LT, which is the rating that has the fewest units of eligibility, 2 per day or 30 minutes per day. And those folks are still going to be eligible, but they're going to be eligible for more units. So they would be eligible for at least 5 units or 75 minutes per day, and potentially more than that, depending on their specific needs. Another key similarity is that the person directs care, and you do see there, or the participant's representative, and sorry, the word representative got on 2 lines there. The participant's representative is probably a new term to a lot of people, but it's the same thing as the responsible party is in PCA. So if a person is unable to direct their own care, which is determined by the assessor, they will still have someone direct care for them, and that's just going to be called the participant's representative in CFSS. And then services that are covered in PCA will also be covered in CFSS. The difference is there'll be additional options. Next slide, please. So when I say services covered in PCA are still going to be covered in CFSS, I just wanted to remind folks about what those covered services are. So support with activities of daily living, still covered. So, support with dressing or grooming, bathing, transfers, those are all still covered, all 8 of them. Instrumental activities of daily living also still covered. And I just have a few examples there, help with laundry or food prep, paying bills. Observation and redirection of behaviors, still covered. And then health-related procedures and tasks, also still covered. In PCA, we're always wanting to make sure that it's clear that that is limited to a fairly specific group of tasks, and that will remain the same in CFSS. Next slide, please. So what's new? Next slide, please. So these are the 6 basic things that are new, and then I am going to hand it over to Libby to talk about a couple of them. Consultation services, a new type of provider that Libby's going to tell us about. Additional possible workers, Libby's going to tell us about that as well, and then she's going to hand it back to me to talk about the ability to get goods and services and or a personal emergency response system, the worker training and development budget, and the 2 models that will be available in CFSS. So Libby, go ahead and take it and tell us about consultation services, please.
Sure. Next slide, please.
Oh, sorry, I forgot I'm doing another slide. Sorry about that, Libby.
Have fun.
So No, go ahead to the why slide. Why are we doing this? It's the next one. Yeah, there we go. So why are we doing this change to CFSS? Why are we putting all this work into doing this? So first, more choices for the people using services. They're going to have more options for how to meet their needs. It potentially reduces the need for having workers. You know, most people are still going to use workers, but you know, they might have some goods that can reduce their reliance on that. Like I said before, that lowest home care rating LT, those folks are going to get some more units. And then there's folks who are using CSG are going to have a bigger budget in CFSS than they had in CSG. It's approximately twice the size of their budget for those people who are replacing PCA with the consumer support grant. And then we do get an increase to our match from the federal government, which helps Minnesota to serve as many people as we can. Now I'll hand it to Libby. Sorry about that, Libby.
No problem. Hi again. Next slide, please. So what does a consultation service provider do? As CJ mentioned, the consultation services provider is a new function in CFSS that is not in PCA currently. So the consultation services provider educates the person about CFSS. It's the first provider that the person who chooses, who is going to use CFSS sees. And so the consultation service provider helps educate the person about CFSS, the types of models. They're going to be, we'll talk about it, but there are two models, agency and budget model. The additional possible workers that I'm going to talk about later, what other workers can be hired, the types of goods and services that can be purchased under the program, personal emergency response systems as well that also can be utilized under CFSS. Then again, the consultation services provider helps the person write the plan if the person desires help. If the person is writing the plan, but the consultation services provider can help that person if desired. The consultation services provider also reviews the plan, goes over it with the person, makes sure all the components are there, and that any and other components that are in the plan are eligible in the CFSS service. And then finally, the consultation services provider helps with ongoing support if needed. It helps, the consultation service provider can talk to the person, talk through things are going right, not going right, things that maybe the person wants to change, other facets on, you know, how to be a good employer, or do we need to change the plan, help build the plan, things like that. The consultation services is there for the person. Next slide, please. So the consultation services provider reviews the plan to see if it is complete, meets the person's assessed needs, and only contains covered goods and services that are eligible for the CFSS service. CMS, which is the Centers for Medicaid and Medicare, the federal government, required us to have lead agencies approve the plan after consultation services reviews the plan. But the goal here is for consultation services to find and work with the person on any issues to minimize the lead agency's work. Next slide, please. Now we're going to speak about what additional possible workers are available in CFSS. Next slide, please. So additional possible workers available in CFSS will be, and they're not workers currently in the personal care program, they can be in CFSS. These will be the person's spouse, parents of minors, and people who also use CFSS. Next slide, please. Next slide, please. So there are some limitations on hours for paid parents and paid spouses. Some people are familiar with the CFSS statute and will notice now that this is a change in the 2023 from the 2023 legislation. A spouse will be able to work up to 60 hours. One parent will be able to work 60 hours. But if there are multiple parents, there can be up to 80 hours, but no more than 40 hours each. And you can see from this slide, we've tried to show you how that would work with multiple parents and in different households or even in the same household. And then CJ will continue about goods and services.
Thanks, Libby. All right, so yeah, we're going to talk about goods and services next. So next slide, please. So goods and services, new to CFSS, this is not an option in PCA. A person can get goods and services. There's some guidelines around those. They need to be related to an assessed need for the direct benefit of the person. And they need to either increase the person's independence or decrease their need for human assistance. And same kind of, I have some examples there. A blender, if, that would be an example of getting food prep that they could potentially do themselves that they couldn't before. One of those grabber tools that someone can use to help with dressing. And you can also see I've got a van there with a laundry basket. That's because they could also potentially purchase a service such as a laundry service, and there would be other potential services they might be able to purchase as well. Next slide, please. So I just wanted to talk really briefly about exactly how that works. And I kind of have a chicken and the egg thing going on here because I've brought up the budget model and the agency model before I get to those. It's kind of hard sometimes to know what to talk about first. The budget model is going to be something where the person gets dollars, whereas in the agency model, similar to what happens now, they get units. So if they're in the budget model and want to purchase goods and services, they're just using part of their budget to do that and part of their budget for personal care. Agency model, they get units like they do now, and some of those units would then go to convert into dollars for them to be able to purchase goods and services. And goods and services are optional. A person doesn't have to do this. It's just an option like these other things. There isn't a slide in here just because I wanted to keep it short about the PERS, the Personal Emergency Response System, but it works the same way. Budget model would be part of their budget. Agency model, they would just convert some of their units to dollars to be able to do that. So then let's talk about the models that I just brought up. So similarities between the models. So again, the person directs care in both models. They write their plan in both models and have the consultation services provider review it. Those new possible workers that Libby talked about are available in both models. And this seems to be something, as we're talking with people using PCA or sometimes agencies, provider agencies, that they're thinking that those new possible workers are only an option in the budget model. And that is not the case. A person can choose that in either model. Same thing with goods and services and PERS. Those are also available in either model. The person is going to use the consultation services provider that Libby talked about in both models. And then again, this was something I didn't have an individual slide on because I wanted not to go over my time limit. But in both models, they'll have a worker training and development budget, which is similar in the agency model to QP units. Currently, a provider agency gets units to pay the qualified professional, which is who supervises their workers. In CFSS, agencies will get a budget. They can use it a bit more flexibly. And then if a person is using the budget model, they also get a budget. They could, just like in the agency model in both models, they could choose to send their worker to a class on something that would help that worker to meet the specific needs of the person. Next slide, please. So what are the differences? And I still have kind of those big similarities there just to highlight those again. But in the agency model, the person or the provider agency is the employer of the person's workers. In the budget model, the person is the employer of the person's workers. So that means an employer means that's the whoever is recruiting and hiring, supervising, scheduling workers and training workers, making sure that they're competent to provide what that person needs, and then firing them if you know that were to be necessary. And so provider agency, they're the employer, they do those things. The person's the employer, they do those things. And then, but in both cases, someone else does the billing, bills DHS, issues the workers' paychecks, because that's not necessarily something that a person would be set up to do. So we have another provider, a financial management services provider, that performs those payroll functions and making sure the person is complying with labor laws. Next slide, please. So how are we going to support you? And I mean you very broadly because there's lots of different people in this audience. So I'm going to start with just the general public. This could be anybody who's interested. We have a growing list of short online videos available on our CFSS website under the training tab. I think we're up to 10 of them that discuss, you know, many of the things that Libby and I have brought up in a little more detail. So I encourage you to go look at those and to share them with anyone else who you think might be interested in learning a bit more about CFSS. We do also have training for specific audiences. So could you go to the next slide, please? So people using CFSS, we are developing 3 different online trainings for those people. And they are meant to supplement but not replace consultation services, because consultation services is helping with all 3 of these things. So they educate the person about their options like Libby talked about before. So we have an online training that highlights for them the differences between the models. And then, you know, that way consultation services isn't trying to reinvent the wheel necessarily every time. They can use that as a basis for the person to understand, and then they can answer questions, you know, that the person has. Again, isn't meant to replace consultation services. Same thing with writing your plan. This can be a guide that the person could use to write their plan. And then if the person selects the budget model, they could use this being in employer training as well. Libby mentioned that was something that we could see consultation services really providing help with is if a person selects the budget model, how do you be a good employer? So again, this would be a tool to supplement consultation services. Those are in development. They are not posted anywhere at this time. Next slide, please. What about the workers? Some of you may know that PCAs are required by statute to take an online test that DHS provides. It's on demand. They can take it at any time. And they do. There's sometimes people have taken it at like 2 a.m. So people take it all the time. We in 2020 replaced the existing one with one that covers both PCA and CFSS, so that as new workers are starting, they're going to get a test that counts for both. So they're still able to meet the statutory requirement for PCA, but now they're also meeting the requirement for CFSS, so they're not going to have to take a new one when we start rolling out. Anyone who took it before that will at some point need to take this training, and we would communicate that well in advance with provider agencies just to make sure. After the rollout's complete, we don't need that PCA information in there anymore, and so we will post one that's just about CFSS. Next slide, please. What about provider agencies? There's already a training posted that, again, at the same website that talks to current PCA agency owners, managers, and QPs about CFSS. If those folks take that test and then submit it with a few other things to our provider services, then they will be able to transition over to being a CFSS agency, trying to make that as easy as possible for them. And then we will have training that would be for new agencies, a new supervisor, a new manager, just kind of like we do right now. It'll be a combination of online and a webinar. Next slide, please. We have online training under development for the financial management services providers. That is not posted yet. Next slide, please. Lead agencies. There is an online training already available for current lead agency staff in a TrainLink, the same place they access, the bulk of the training that DHS requires or offers for them. And then we have another one that's under development that would be for new lead agency staff. The one that's there assumes that the learner knows some stuff about PCA. And then during rollout, we're going to have office hours for lead agencies because we know, just like our MnCHOICES team, that things are going to come up that we want to support lead agencies with as we go. Next slide, please. The consultation services providers, we have been working a lot with these folks already. We've made extensive online training available for them, again, in that TrainLink system. We've been having webinars both in 2022 and 2023. We're going to have office hours for them as well. And then we've got even more online training under development because we know that we really want those plans to get to the lead agency in a really easily approvable form so that we're not overburdening the lead agency's time. Next slide, please. Timeline. This is always the million-dollar question. We have decided on, instead of giving a specific date, to say that we will give at least 90 days notice prior to launch. We're doing this so people don't necessarily have a specific date in mind right now because we still are working on some things with the Centers for Medicare and Medicaid Agency. They have to approve our plan. And so we decided instead to just make sure people know we're going to give you notice so that we're not springing it on you. It'll start on the first day of whatever month it is. And then people will transition at their annual assessment. Whenever they would have had their annual assessment for PCA, they'll have the assessment like normal, and then they will start on CFSS. Intersections with other initiatives. And I do want to apologize, in the PowerPoint that went out, there were several question marks after Waiver Reimagine. That is because in my initial draft, I wasn't sure about that and meant to consult with colleagues, and then it accidentally ended up in the one we sent out. I assure you there are people at DSD and aging who know all about this. I simply wasn't one of them, and so that's how that accidentally ended up in there. CFSS, like Lori and Darci talked about, is built into the MnCHOICES application. EVV will apply to CFSS, so that's an intersection there. And then Waiver Reimagine is not going to have an impact on CFSS eligibility. So next slide, please. Speaking of Waiver Reimagine, that's our next topic. So I would like to invite my colleague Meghan Lindblom to go ahead and talk about that. And Meghan, your title, right, is Program Integrity Supervisor, right? So take it away, Meghan.
Thank you so much, CJ, and thank you for everybody who's still on the call hanging in there. A lot of really good information today. My name is Meghan Lindblom. As CJ said, I'm the Program Integrity Supervisor. My team generally oversees the budget transition as part of Waiver Reimagine, though I am only one of many people in DSD working on the Waiver Reimagine project, representation from across the entire division. So you're seeing me today, but I'm representing lots of our staff. So if you go on to the next slide, please, we will get into our content. So Waiver Reimagine, what is it? We hear a lot of confusion or a lot of people saying, oh, well, that change that just happened, that was Waiver Reimagine, right? And what I really want to focus us in on today is that it's the name of some ongoing work that DHS is doing and will implement, which are three main tenets. The first is to reshape the waiver program structure. If you've heard about Waiver Reimagine before, you may have heard of this talked about as the transition from 4 disability waivers into 2. Another item here is to expand the informed choice and informed decision-making for Minnesotans accessing services, really making sure that people have the ability and access to dial in to really guide their services and their life. And last but not least, transitioning into an individual budgeting model for people who access the disability waivers. And this is a transition from a much more broad budgeting model into really focusing on what are the needs of the individual and accessing the funds that way. These changes will link to a person's needs spent on their service plans, and services and supports will hopefully align with a person's need, not their diagnosis, right? Moving away from these diagnosis-based waivers into support planning that really fits the whole person. Next slide, please. So to talk a little bit more about what it is and the visual on the screen for those of you who may need a little bit more guidance here is on the left side of the screen, we have 4 rectangles that are lined up and each has a name of the disability waivers that we currently have. In the middle, we have a very large blue arrow pointing to the right side of the screen, which is represented by 2 rectangles that represent the new waiver structure that we have proposed. And so I just wanted to identify that for you all. And then through multiple years of research of identifying efficiencies, simplifications, and improvements, we will be reshaping the 4 disability waivers. In shorthand, that's the BI, the CAC, the CADI, and DD waivers into the 2 waiver structure. The new 2 waiver structure simplifies the waiver programs by aligning waivers based on where people choose to live rather than their diagnosis. Right now, a person's diagnosis or required level of care determines their eligibility for one of the 4 current disability waivers. Both of the new waivers will encompass the 4 levels of care and other eligibility criteria associated with the 4 current waivers. As a result, eligibility requirements will remain essentially unchanged for people who use services. This is intended to create unity between the 2 waivers, increase equity, and make them easier to understand and navigate. Next slide, please. So, Waiver Reimagine. Why is it happening? Why are we doing this? This is a pretty big thing, right? And we're now 5 years into it and have years ahead in the future. It's a big effort. So why? The current service system was developed one piece at a time and one program at a time over the course of many years, in actuality, decades. And we've heard from people and families that the Minnesota Disability Waiver Programs is complicated, inequitable, and limits their flexibility. Disability waivers are developed around diagnoses and criteria for institutional care. As waivers were added and evolved throughout the years, they became increasingly complex and different services available on different waivers, different names for similar services in some cases. And these variations in the waivers created a lot of inequitable access for services, right? A thing we commonly heard in our early conversations is it feels like there's a secret password or a knock that I need to know to access the service and the supports that I'm looking for. Waiver Reimagine changes are based on the feedback that we've heard over years about things that needed improvement, not just within this project, but the years leading up to it, right? We get feedback continually from you all through many channels, and we want to make sure that we're not only listening, but reacting to what we hear from you all. Next slide, please. So Waiver Reimagine, when will it happen? Like CJ just said, that is the $1 million question, right? What's the timeline? When can we expect these things? And I do want to call out here that we have a pretty long timeline ahead of us. and that we've also actually hit some milestones as well. So back in 2021, we completed what was known as phase 1 of Waiver Reimagine, and you all may have experienced that in changes to names for services, and that was one of those big pieces, right? Different services that were almost identical had the different names on different waivers. You had to know all of these names. So we aligned the service menu, and that was something that began implementation in January of 2021. And so that is something that has changed under the Waiver Reimagine project. But beyond that, there hasn't been any other implemented changes. So if things are changing in your programs or you're experiencing that, these aren't necessarily Waiver Reimagine, but could be due to a different policy change as well. When we talk about Waiver Reimagine phase 2, the bringing on of those 4 waivers, expanding more and more into the informed choice lane and the individual budget methodology, that's something that we're looking at into the future, and that it will be implemented no earlier than January of 2026. Though I want to call out here that Waiver Reimagine is dependent on the successful implementation of the new MnCHOICES revisions platform. And that's because our budgeting methodology is built on the MnCHOICES 1.0 assessment. And we want to make sure that our assessment and budgets are all fully aligned, tested, and made sure they're working well together. So that is part of the delay we're looking at today. Next slide, please. So a big part, like I said in an earlier statement, not we, it's just me today. A big part of the why is expanding what we call choice and control. Those are the terms that we use, but it's really bringing people into the conversation about their own lives. So we're looking to increase choice and control for people receiving services and their families by making it easier for people and families to describe the services they want, right? We've even done that a little bit with the transition in 2021, making sure you didn't have to know 4 different names or the correct word, but understanding what the service menu is. We're looking to enhancing process for informed decision-making, really making sure that there are tools and resources out there for people and families to better understand their options before they ever come to a support planning conversation. Providing a consistent service menu and funding across waiver programs, regardless of disability and in which county or tribal nation a person lives. We do know there's inequities when it comes to funding across the state based on our historical models of funding. If you walk into the door asking for services in a small county with a small budget, it may be harder for them to serve you, and they may not have as much access. So we want to make sure that we have equity across the state and access points for everyone to have the same experience based on their support needs. And then last but absolutely not least, increase options to self-direct services, use technology and remote supports as alternative support options, and having a choice about where you live and work. Next slide, please. A big piece of this transition is the change in the funding mechanism or budget, any of those words that you want to use there. But ultimately, we are changing how money flows to a person in this change. And so again, this is about choice and control, but I want to highlight kind of what we're using today and what that will look like in the future. So our current budget methodology is that there really is no one specific way to determine how a person can spend for traditional waiver services. And when I say traditional waiver services, I mean provider delivered. We do know that with the CDCS program, there is an individual budget that we have for the disability waivers today. And that is outside of what we're talking about with the county budgeting system, but it still does play into how much a county can spend. And so the person has their pot of money, but it may limit how the county can spend outside of that. So each lead agency or county and tribal nation is required to balance people's needs within an aggregate budget that is allocated out by the state. So they're balancing everybody's need. What you need and what you get is balanced against the person who came before you and the person that came after you, which can sometimes lead to inequities based on people's ability to advocate for themselves, understand the complexity of the program, language and or cultural barriers, all which can really put up a wall to people accessing services that they need. With the individual budgeting methodology, each person is assigned a support range budget based on the results of their MnCHOICES assessment. And again, that connection with MnCHOICES is really important here, and part of the reason we're looking at an implementation date no earlier than 2026. From there, a person chooses which services and supports to access within their budget, right? No longer do we have to compare to the person coming before us or the person coming after us, but we just look at the individual and their assessed needs based on their MnCHOICES assessment. Next slide, please. And I've talked about this a number of times, but we really want to stop and call out that a big goal and outcome of the Waiver Reimagine project is also increasing equity for these programs, right? Ensuring equitable access across the state, simplifying those waivers to be more person-centered, consistent budgets and services based on a person's assessed need, not the lead agency's budget or the history behind it. Increasing measures to expand informed choice and enhance support planning processes for equitable service delivery, and acknowledging historical inequities to improve access over time. Next slide, please. Another thing that I've hinted at already, but to call it out specifically, community engagement has been an enormous part of the work before the project started, throughout the study period, and now as we get ready for implementation and under developing the policies and procedures that will support us into the future. This is something that is both formal and informal, so I want to really call that out. We've done extensive amounts of community engagement, working with lead agency partners, people and families, and service providers themselves. But if we haven't gotten to you yet, don't think that we're not trying to. So if you're interested in connecting with the Waiver Reimagine project, providing your feedback, there's lots of ways, and we'll talk about that, to get in connection with us, as well as some upcoming opportunities. So to talk about it concretely, multiple outreach efforts have been taken on and moved through since the 2018 period. So we're now in year 5 of this project, including focus groups, community meetings, and tons of individual conversations as well. We launched in, I think, 2022, but the law requiring us to do so was passed in 2021 for a Waiver Reimagine Advisory Committee. This is a group that we meet with every other month. It's 30 individuals that is mostly representative of people and their families, with representation from lead agencies, providers, and advocates as well. We actually have a meeting with them in 2 days. We're really looking forward to our next conversation. We also have some upcoming focus groups with a contractor, and we're looking later this year. So keep an eye out, especially on those e-lists like we talked about at the beginning of the meeting. Notifications will go out about how to connect with those conversations if you're interested. And we've really been expanding in the last year and a half our conversations with tribal nations, making sure not only are we treating them as our lead agency partners, but understanding the unique needs of our tribal nation partners when it comes to this transition and their interaction with the waiver services and programs overall. Next slide, please. So to break this down just a little bit, what's changing, what's not, we're going to talk about this with 3 separate groups. The first being people and their families, which is the main focus of the Waiver Reimagine change, right? How are we meeting the needs of people who are served by these waivers and have access issues as well? So what will change? There'll be an individualized budget. That's a whole new, brand new thing. If you're a CDCS user today, you might be a little bit more used to it. But for the majority of people on the waivers, they may not even know how much they're spending in a year on their services. So that's going to be a new thing that we all have to get through and conquer together. And again, make sure that we're helping people access information that empowers them to have decisions about their lives, even in a budgeting space. We will be increasing informed choice training and information. So DHS will enhance training for lead agencies to ensure people accessing supports are offered informed choice and informed decision-making opportunities. Again, and that ties right back to budgeting and knowing those simplified services and expanding options for self-direction. What will stay the same? People will still need to meet the current level of care eligibility requirements as they do today. That process will not change. An assessment is still required. DHS is not adding new services to the waiver programs as we transition from 4 waivers to 2, so we will incorporate the current services in the 4 waivers into the new programs. That means that there's going to be stability across those services during this transition period, which really helps, like, new things aren't going to be popping up, so you have to learn them on the fly while you're learning and transitioning. And then ensuring consistency and transparency in the allocations of funds across the state, really making sure that if we say you have an individualized budget, you should know what went into that, the decisions, and how you can even understand the basics of what we're talking about and why the amount of money is what you have. Next slide, please. So what's going to change for our lead agencies, which are for these programs, mostly counties and tribal nations? You will no longer need to manage a county waiver budget. And as the team that does a lot of the budgeting, both currently and in the future, I will say this is one of the biggest things we hear from counties. I think my favorite thing they've ever shared is that, hey, I got into social work to help people, not do math. And so that's one of those things that we can take back and use our expertise at the state and free up some time for counties so that they're not managing large waiver budgets, but are really focusing on supporting people. There's no longer a 30-day wait for budget calculations for CDCS people or case managers who support them. You guys know how long it can take to get that budget amount, right? And it's a historical fact, but in the future place with those individual budgets, it should be pretty instantaneous to be able to determine what budget a person will have, and we won't have to wait 30 or more days to get that. Case management simplification coming in with new requirements and hopefully helping case managers have less complexity to wade through. Another thing that's changing is applying policies consistently and equitably across the state, making sure no matter if you walk in the door up in St. Louis County, down in Rock County, or even in one of our metro counties, that you really are, you know the rules and how to apply them, and it's not necessarily layers on layers of additional rules. And enhancing training and practices for providing informed decision making as well. So we talked about that with people, but we also need to make sure we're supporting our lead agency partners, that they have the tools they need. What's not changing? Slot management or allocation management for the waivers. This is very insider baseball, but really what this means is people still need to access the waivers in the same way, and it's a federal requirement. So lead agency partners, if you are doing slot management, that will be something we have to continue into the future. So it's not all going away, but some of it is. Next slide, please. And last but absolutely not least, our service providers. Waiver Reimagine impacts our service providers by standardizing practices across the state. That's something we hear from you very frequently. Hey, it's really hard because the rules are different in every county. Applying policies consistently in equity, right, across the state, like we just talked about, and simplifying processes and creating clear information that has a positive impact on providers. Providers will continue to deliver person-centered services as identified in the Person Support Plan, Service Agreement, and according to requirements. Next slide, please. So if you'd like to learn a little bit more about Waiver Reimagine, the slides that were sent out to you in recent days do have these hyperlinks ready for you. And I would say your first stop really should be that first link, which is the Waiver Reimagine website. We've done a lot of work, and we continue to do a lot of work to make sure the most up-to-date information is available to everyone, creating as much transparency as we can so people know what to expect. So things like the frequently asked questions that are linked there are on that website. We have a great resources tab that has hundreds, if not thousands of pages of research that we've done and published for the public to better understand. If you want to know how that new individual budget is scored on the MnCHOICES 1.0 assessment, what goes into that, how all of those numbers were created and came up with, it is all there, page for page, believe it or not. You could also subscribe to the e-list announcements like we talked about at the beginning of today's big presentation. Those are a great way to get information in real time from us. And like I said, there's an opportunity to connect with us if you'd like to. And that would be emailing us at the actual Waiver Reimagine website that's linked right down there. And if you don't have time to go find that, it is waiver.reimagine@state.mn.us. Pretty easy to remember. And we're always happy to get back to you. Please give us a few business days. It's not instantaneous, but we will do our best.
Thank you so much for that, Megan. We're about to begin the question and answer session. Before I begin, I just want to remind everyone that we probably will not get to every question because there were close to between 30 and 40. However, we will do our best to try to combine as many of them as possible and answer as many as that were requested. I'll start with Amanda Tamte. You mentioned that you were able to consolidate the 8 or 9 into 3 responses. Would you be able to provide those questions and those answers for us?
Yeah, so I'm not able to answer all of them today, but I did take the main points away to answer some of the main topics. So one of them was for a visit to be verified with no internet access or mobile device, what is the expectation for verifying those visits? So within the HHAX system, there is an offline mode, and once the device is connected to internet, it will then upload the visit to the system. We also have the IVR option with HHAX for those places that do not have internet access or access to a mobile device. We are live with IVR, but it is in a rolling implementation that started at the beginning of this month and is planned to roll out through October 1st. And the IVR is only available in English at this time. So there was a question about getting access, so please be patient as we roll out those lines to providers using HHAX. And third-party systems will need to work with their vendors to meet the needs of no internet access or mobile device access. For implementation and notice of when the full implementation will be required, we know that providers and caregivers and members need time to learn the system. We are not enforcing compliance that will result in claim takebacks or denials in 2023, but we are still monitoring the EVV usage as we move towards compliance. So this will help us onboard and make sure people are ready for those compliance requirements. We also are required to report to CMS quarterly to identify the providers that are using and not using the system, and we'll provide technical assistance as we continue to move towards those compliance requirements. And the last big one was about live-in caregivers. And so providers are responsible to ensure that live-in caregivers meet the live-in caregiver policy and monitor them logging on a daily basis. And the webpage, our DHS webpage and our CBSM have been updated with the current requirements for live-in caregivers. And you can find more information about live-in caregivers under the resource tab on the Minnesota DHS EVV webpage. And that'll also link you out to the CBSM policy. So those are the big ones, Todd. I'll hand it off to the next.
Thank you so much. I will now jump to Lori and Darci. They were able to also identify and prioritize 3 questions. I'll start with the first. Has there been testing of MnCHOICES to see how it impacts rates of people who have been receiving services?
Thanks, Todd, for the question, and we will go ahead to answer that. I can say that the testing of rates has been done through the beta phase that we conducted. where we had lead agencies in the system testing a variety of things. Rates was part of that testing. We have also done lots of internal testing of the rates. Darci, I don't know if you have anything to add to that.
Nope, nothing to add.
All right, I'll jump to the next question. Can you describe, in a nutshell, how MnCHOICES 2.0 differs from MnCHOICES 1.0?
Well, that one is a difficult one because it's such a big project. But we'll do our best to kind of do that little elevator speech for you. So first, and most importantly, the policy and rules have not changed. The look and functionality of the application, yes, that is very different to what it has been. It differs. The main difference is having everything under one roof, we call it. So you've got the house and everything lives within it. You're not going out for other things. The support plan's there. There are OBRA forms. There is the helps document. All lives within there. So with having all the forms under one roof, we also have messaging between agencies that can happen. They can upload documents and share those. There's bulk assignments, user management, and then we have all lead agencies using the one system. So again, living under the one house. That's managed care organizations who were utilizing paper for conducting their LTTCs and creating support plans are now in the application.
Awesome. I'll close it out, or at least this section, with your third question. Will assessors who are still doing the PCA assessment be required to use the MnCHOICES assessment? And when will this happen?
Sure. I will take that and say the answer is yes, they will be required to do the MnCHOICES assessment. PCA assessments can now be conducted within the revision, even though the system is built for CFSS. Within the system, we have provided a CFSS to PCA worksheet that assessors can use now. And then we have that the use of legacy tools will be allowed through May of 2024, and then the legacy systems are going down. So beginning June 1st, 2024, all PCA assessments will be done in the revision with the exception of contracted PCA. Contracted PCA entities will continue to use legacy until all those assessments have been transitioned, or all those reassessments have been transitioned to the MnCHOICES revision.
Thank you so much. Any other additional comments on that before I jump to CFSS?
I'll turn it to Darci. Do you have anything to add, Darci?
Nope, you covered it. Thank you.
All right, well, thank you so much. As for the CFSS section, due to the volume of questions, I've asked CJ and Libby to consolidate them into their top three, at least for this first part of the session. Take it away, CJ and Libby.
Thanks, Todd. And yeah, and unfortunately, we weren't necessarily able to condense ours like some of the other folks are, because they were kind of all over. So I'm going to answer three ones that I thought seemed pretty important. And then if we get another round, Libby is going to answer some more. So this was an important question I wanted to make sure to answer. Will consultation services be paid out of the individual CFSS budget? No, there is a separate bucket of money that pays for the consultation services. It is completely separate from the funding for the person's other CFSS services. Do all people that use CFSS have to have a written plan now? They do. That is not a change from PCA. All people using PCA need to have a written plan, and all people in CFSS, regardless of the model, need to have a written plan. And then regarding the CFSS budget model, will an agency have any relationship with the person, or are they independent from another? If a person selects the budget model, they will work with a financial management services provider to provide that payroll and other kind of administrative tasks, and then they are the employer. They will not work with a CFSS provider agency. That would be for the agency model only. And thank you, Todd. That's it for those three.
All right. Well, I'll jump to Meghan for, I think she may be able to cover all of them. The first one is, can I ask why AC and EW waivers are not included in so many of these programs? This is the Waiver Reimagine section, by the way, such as Waiver Reimagine.
Sure. And, the bulk of what I can say to that, and I can't speak to the other efforts that may not include that, is just this was a conversation and a study that we did and initiated for the 4 disability waivers. We've had a number of conversations about bringing in AC and EW, but at this time it is not something that we're exploring.
Okay. I'll jump to number 2. Does EVV replace the requirements for HCBS documentation requirements stated in 256B, 4912, subdivision 12C and D? And this may be also for the first part, the EVV section, but it was posted late. And if it's not, if it is for you, Meghan, I'll give you first shot at it. Or is EVV the way this section is implemented?
So it's 256B, 4914, 12C through
C and D.
C and D. Okay, I'm scrolling furiously as we talk about this one.
They put .4912, if that.
4912, I cannot speak to. 4914, I can. So that is not something that I can speak to, though I think maybe we can circle back with the EVV team on that one, potentially. But do you have any other questions for me, Todd?
Well, I'll just add a comment that somebody added that what you were mentioning was great news, that there will not be a 30-day wait for budget calculations. So some positivity. And then the last one is that you stated that the budget ranges are based on MnCHOICES 1.0. Are all the budget ranges going to be recalculated after the first year of revised MnCHOICES data?
That's exactly it. So that's one of the reasons we see such a long timeline in front of us is we have a budget that is built on a person's assessment. And so we need to make sure that that assessment lines with the budget. So once MnCHOICES is fully implemented, we can start a year clock. We need that full year of information, right? Because that's everyone's assessment, capturing everyone. And then we'll go back and revisit our statistical analysis, as well as all of the major steps that we did to create that budget initially back in 2018 and 19. So that's something that's huge. It involves a ton of stakeholder engagement. So look for that hopefully sometime in 24 and 25. Sorry, I'm getting my years mixed up these days. So that's something we'll look forward to as we get more of our MnCHOICES data available and align it with our new MnCHOICES revision assessment.
All right, thanks so much. I think we have time for one more question for each of the presenters. And I think since we asked all of yours, Meghan, you get to take this round off. We'll start with Amanda Tamte. Was there any of the remaining questions that you'd like to get to?
Answered all the ones. I think I've answered all the ones that I can answer right now, but I have noted all these and are going to bring them back to the team so we can ensure that we're able to respond, whether through our FAQ or webpage updates.
Okay. All right, we'll jump to MnCHOICES. Lori and Darci, and there's a question about CFSS replacing CDCS, I believe. Yeah, feel free to answer that one.
Well, Todd, that one is not a MnCHOICES question.
Oh, oops, sorry. Oops.
I would not be the expert to address that.
Sorry, that preview to the next group. I can throw, I'll do this one. Can you talk about how MnCHOICES assessors are trained to make sure the data they gather is accurate?
Yes, Todd, I can take that one. That one's in my swim lane. So through the certified assessor training, which we call MnCAT, there are training modules that assist the assessor with walking them through how to gather enough information, how to dig deeper in order to fully understand the person's need and get the information that's needed to select the appropriate response. We also have the assessment practice guide that is in the Help Center of the revision application. And the assessor can go there real time and also receive tips on how to, just like I said, dig deeper into getting to know the person and really understanding the situation. Then assessors can also access DHS subject matter experts for assistance on complex cases. And through 25/6B/0911, there is to be a long-term care consultation team. And that team consists of a social worker and a public health nurse or registered nurse, and the teams can consult together.
Thanks so much. And then the final question to CJ and Libby, the one I mentioned too early about replacement.
Hi, yeah, the question about will CFSS replace CDCS? That's a no. CFSS is not replacing CDCS. And there are many other questions that are similar to this as far as what about CDCS and a person who is on a waiver is going to move to CFSS and not have CDCS. CDCS is a self-directed option available to people who are eligible for the home and community-based waiver services programs. So of all the waivers, CDCS is still going to be available, and it's a service option on how to direct your own services when using waivered services. It is very different than what CFSS is going to be. CFSS is replacing PCA.
Thanks so much to all of you. And I also want to thank all y'all for spending your time with us today. Just a reminder, we will be sending out a post-event survey and certificates of attendance within the week to people who have participated in this webinar. Please email any remaining questions to dhs.odyssey@state.mn.us. And stay tuned for our future 2023 Odyssey webinar series events on the Odyssey Conference website and the 2024 and 2025 editions potentially. Next slide. I'd also like to remind everyone to sign up for the AASD DSD Stakeholder and Lead Agency e-list. We're sharing the QR code again, and we'll leave it up for a few minutes so folks can scan and subscribe. I would like to extend a huge heartfelt thank you to our presenters for sharing their time with us today. It has been so valuable to hear from you all. Lastly, thank you to all of you in the audience for joining us today. We hope to see you at our next webinar. Thanks again.